Ribs by Tucker Sauter. We will begin our ribs x-ray by performing ADET and obtaining a quick history of what happened and why the patient is here. Our exam will differ based on where the pain is reported by the patient, who is currently reporting lower posterior and side rib pain. Rib x-rays are typically ordered to assess for suspected rib fractures after trauma or sometimes to investigate localized chest wall pain. However, keep in mind that many rib fractures are subtle. The treatment is usually the same whether or not the fracture is seen, so clear clinical indications are important before proceeding. This patient has indicated pain in the posterior side near the axillary portion of their ribs, so we will begin the exam with the antero-posterior projection, allowing the ribs of interest to be as close to and as parallel with the IR as possible. Our central ray will enter perpendicularly at the level of the xiphoid process, or, if our pain were any lower, midway between the xiphoid and the lower margin of the ribs. Our technique will vary slightly from exposure to exposure, as we will need our heterogeneous X-ray beam to penetrate through slightly more tissue in the oblique projections. For our first projection, we will set our technique to 80 kVp at 10 Mass. This will allow our X-ray beam to penetrate and black out the patient's lungs while allowing the ribs to attenuate the X-ray beam, creating a clear radiograph of the anatomy of interest. A patient may ask for shielding to protect anatomy that is not of any interest. Shielding recommendations have changed recently, and it may be safer for the patient to remain unshielded, as the lead barrier can cause scattered radiation to rebound off the inside of said barrier and expose the patient more than necessary. Next, we'll need oblique views that specifically target the ribs on the side of concern, either the left anterior oblique or right anterior oblique, depending on whether it's the posterior or anterior ribs we need to see better. These views are a part of most site protocols already, but are especially important when pain is indicated in the axillary region of the rib cage. It will be necessary to turn the patient's whole body approximately 45 degrees from the IR. If the patient cannot hold up their arms, they may rest one on the upright bucky and the other placed akimbo on their waist. Here, we see both positions done. This will help us examine the entire length of our axillary ribs. Our central ray will enter the patient perpendicularly at the level of T7, 1 inch lateral to the MSP on the raised side of the patient. As mentioned previously, this view will require an increased technique. 81 at 16 ought to do. Now let's discuss some other views that can be used, as well as our breathing techniques. Differences in how this exam is performed is why it is so important to collect as many clinical indications as possible when obtaining the patient's history. If the patient were to indicate pain on their anterior ribs, it is more effective to take our initial exposure in the postero-anterior position. Like a chest x-ray, we will roll the patient's shoulders forward to remove them from the lung field. And also, like a chest x-ray, our central ray will enter the patient perpendicularly at approximately the level of T7. If necessary, ask your patient to refrain from making googly eyes at you. Breathing techniques will vary based on where the patient's pain is. Our patient has indicated pain towards their lower ribs, so the most effective method of isolating those ribs will be to take the exposure on full expiration so as to raise the diaphragm above those ribs and out of the area of interest. However, if the patient has indicated upper rib pain, ribs 1 through 8, we'll need to depress the diaphragm by taking our exposure on full inspiration. Look at him go. Nobody puts baby back ribs in the corner. Here we have some rib x-rays. As we can see, proper collimation of 14 inches by 17 inches has been employed. When imaging the upper ribs, we can see 9 posterior ribs in their entirety. This is an indication that the proper breathing technique has been utilized. When examining our lower posterior ribs, we can see how effective our exposure at full expiration was, as it has left significantly less overlap between the lower ribs and the diaphragm, resulting in a clear image of those ribs. Lastly, our oblique projections show our axillary ribs free of superimposition of the thoracic vertebra. It can be difficult to tell if you have under or over obliqued your patient when taking these exposures. However, an easy way to tell you have proper patient angle is to examine their shoulders. On one side, you'll see a Gracies, and on the other, you'll see a perfectly lateral scapula or a scapular Y view. You'll also notice approximately twice as much distance between the vertebral column and the lateral border on the affected side as on the unaffected side. One last thing before we go. It can often be difficult due to overlapping anatomy to identify exactly where a patient's pain is, especially for a radiologist. So what we can do to help them interpret our images is ask the patient to take a lead, BB, or other radiographic marker and place it directly on the skin. What that does is point out on the radiograph exactly where it hurts the most for the radiologist, making it easier for them to interpret the image. So again, just place it directly on the skin, right where it hurts the most. Dry ice is really fun, but it's important not to leave anything in there, like this. I want my baby back, baby back, baby back, baby back. Make me a ribs X-ray.